much, Dr. Ajay Paul sir, for the kind introduction. I'd like to thank AIUS for giving me this opportunity. My grateful thanks to Dr. Lalit Verma sir, Dr. Namrata Sharma, Dr. Harbans Lal sir, and Dr. Rajesh Sinha. Can you hear me?
Yeah, we can hear you.
And you can see my slide?
Yes, we can see your slide and we can hear you clearly.
Thank you so much. So I'll be talking about planning cataract surgery in uncontrolled diabetes. And one thing which I would like to request all the attendees to note that we will be talking about uncontrolled diabetes, not only who are having a higher level of sugars and then getting it controlled. Now, diabetes, as we know, India is becoming one of the major capitals in the world as far as diabetes is concerned, and especially with after this COVID has happened, the incidence of diabetes is going to increase more with the use of steroids. So now, generally in this, we see that wherever the per capita income is higher, the incidence of diabetes is higher. Even though in this slide, as we see in the state of Bihar, the incidence of diabetes is lower, but I think it's pretty much underreported. So we have to be very careful. And I was doing a research on literature research on the endothelial cell loss in uncontrolled diabetes, and there was very limited literature that I could find regarding this. So diabetes mellitus is one of the major diseases worldwide, and the prevalence of diabetes has risen significantly in the past several decades. And post-COVID, the incidence of DM has risen many folds. Recognition of clinical manifestations of diabetes on the cornea is very important for the development of treatment strategies, especially in cases where ocular surgery is needed. Now, cataract surgery is associated with endothelial cell loss, as we all know, and uncontrolled diabetes mellitus. It used to be a contraindication, not anymore, but for refractive surgery. Nevertheless, diabetic patients who undergo cataract and LASIK are at significantly higher risk of developing post-operative epithelial complications. Although one of the major complications of diabetic eye is diabetic retinopathy, corneal diseases can not only develop in diabetic patients but are also difficult to manage, because most of the lasers and all that the retinal surgeons have to do, they have to get a good view, and for that the cornea has to be in good health for them to do a good laser. It is known that neuronal abnormalities directly affect the visual function in patients with diabetic retinopathy, but they may also be the cause of corneal changes in diabetic keratopathy. The findings of the anterior segment in eyes with diabetic keratopathy are more difficult to visualize than those of the posterior segment. When we are busy in our day-to-day regular OPD, sometimes we can miss subtle signs which are there in the cornea in patients, especially with uncontrolled diabetes. Although the cornea may appear disease-free in diabetic patients, marked biochemical and ultrastructural abnormalities altering its functions can be present. Now, we'll be talking more about the endothelial cell loss. The diabetic neurotropic keratopathy is a component of diabetic polyneuropathy and recognized to be the cause of morbidity of the cornea in diabetic patients. In addition, corneal endothelial cell damage can cause disturbances in the management of proliferative diabetic retinopathy before and after the surgery because of endothelial decompensation with bullous keratopathy. The early diabetic changes of the anterior segment include endothelial changes such as Descemet's membrane fold and pigment deposits in the endothelium. There have been only a limited number of studies that have focused on the importance of corneal diseases, especially in uncontrolled diabetics. Endothelial cell dysfunction may place the cornea at greater risk of developing endothelial decompensation with bullous keratopathy. Diagnosing diabetic keratopathy at an early stage will help initiate appropriate treatment for preventing further complications. This we all know, we have been seeing since our postgraduate days, a scheme of advanced glycation end products, accumulation and their effect on the corneal tissues. AGEs accumulate in diabetic corneal cells and induce nuclear oxidative DNA damage, and finally the corneal cells die by apoptosis. On the other hand, AGEs accumulation enhance collagen cross-linking. Black spots enhance the AGEs accumulation in the corneal tissue. Now, this is a scheme of endothelial cell dysfunction in diabetes. Hyperglycemia reduces the activity of sodium, potassium, adenosine triphosphatase of the corneal endothelial cells. This leads to morphological changes of the cells which progress to corneal decompensation. Now, patients with diabetic keratopathy have impairment of epithelial basement membranes, epithelial wound healing is compromised, epithelial stromal interactions, endothelial function is compromised, and the nerve functions are also compromised in these patients. The corneal disorders associated with diabetic keratopathy are characterized histologically by subepithelial deposits, thickening of the subepithelial basement membrane, and altered morphological appearances of the corneal epithelium and endothelium. There are not only ultrastructural changes throughout the cornea, but also alterations of the tear film in diabetic eyes, resulting in ocular discomfort, burning, and foreign body sensation. The severity of the tear film dysfunction is significantly correlated with the severity of the diabetic retinopathy. A greater tear film dysfunction in eyes with more proliferative changes of the retina. This is something which are coming in newer literatures, which show that the tear film dysfunction is associated with proliferative changes in the retina. It was suggested that one or more of the following events may lead to the alteration of the tear film and ocular surface of diabetic patients, and that could be due to the chronic hyperglycemia, corneal nerve damage, and impairment of insulin action. Patients with diabetes had less nerve fiber bundles in the cornea than healthy control subjects, possibly due to the presence of polyneuropathy. These findings may account for the decreased corneal sensitivity in the diabetic patients. Due to epithelial dysfunction, patients with diabetes and diabetic retinopathy are at increased risk for developing corneal disorders such as epithelial defects, recurrent epithelial erosions, decreased sensitivity, delayed reepithelialization, abnormal wound repair, and increased susceptibility to injury and ulcerations. There is increased corneal thickness has been reported in diabetic patients. However, the exact cause is still unknown. There are several possible explanations such as inhibition of the endothelial pump, increased stromal swelling pressure by a given thickness, or increase in the endothelial permeability. Several studies on the corneal endothelium in diabetic patients reported a decrease of the cell density with polymegathism and pleomorphism. However, the percentage of hexagonal cells in diabetic patients was not significantly different from that in non-diabetic patients. Now, protecting the ocular surface is crucial in diabetic patients due for phacosurgery because diabetes affects all the components of the tear film. The use of artificial tear lubricants are very important, especially during post-operative period. It is necessary to carefully examine functional disorders in diabetic patients suspected for the diabetic keratopathy, including disorders in the permeability of the corneal tissue before ophthalmological procedures such as cataract surgery. Even on the day we are doing biometry, it is very important that we do a random blood sugar because corneal thickness is increased in sugar levels above 300 milligram per deciliter, and this in effect can can affect the biometric calculations. And it's also very important that perioperatively we use topical non-steroidal anti-inflammatory drugs to prevent macular edema as a prophylaxis following cataract surgery. The role of perioperative non-steroidal anti-inflammatory drugs used in cataract surgery, recent literature establishes the efficacy of a newly available intracameral phenylephrine NSAID combination for pupillary mydriasis, post-operative NSAID used for preventing CME in certain high-risk populations, and post-operative NSAIDs for controlling pain and inflammation. And especially in diabetic patients, we have to be extra careful about the macular edema. However, further high-quality studies are required to determine long-term effects of perioperative NSAIDs on visual acuity and CME rates. It's very important that when you are using operating on a patient who has sugar levels above 200 milligram of deciliter, that time you should get a special consent form signed. While AIUS CME series says that you should be operating below 200 milligram per deciliter. In some studies in American Academy of Journal, they have said in clear corneal phacoemulsification surgeries, it can also be done below 300 milligram per deciliter. In conclusion, I would like to say that chondroitin sulfate and sodium hyaluronate must be used in all patients with uncontrolled diabetes undergoing phacoemulsification, and tear films also must be used post-operatively, tear drops, and a random blood sugar test must be done in all patients on the day of the surgery also, especially who we know have uncontrolled diabetes. Thank you so much for your patient hearing, and we would like to welcome all of you to Patna on 6th, 7th, and 8th of January for the AIOS midterm conference, which is due to happen in coming January. Thank you so much for your patient hearing.